back when she was transplanted, we never talked to our patients about surviving for 10 or 15 or 20 or 30 years. Mm-hmm. But if you look now, I mean, we tell our liver transplant recipients now that the average survival after a transplant is close to 20 years, something that was unimaginable 2 decades ago as well. So she was a little bit ahead of her time in terms of how enduring she proved to be.
When you look back, I mean, she was only 2 years old, and her parents were fighting the system to try and get her a liver.
Exactly. Yeah.
How have things changed since Lindsay got her liver?
Well, I think there've been several fundamental changes. Transplantation 25 or 30 years ago was still considered somewhat experimental. And it's been recognized now, I think, for most of that time as being the standard of care for patients with end-stage liver disease, both adults and children. So when I started doing this in the early 1980s, transplantation was a bit of a hit and miss proposition, and now it's something that we do every single day, and we have excellent long-term results. So I think the acceptance of transplantation has grown, and the fact that it is so successful, I think the word is getting out. People really don't realize it until they hear it, that we have patients that are now in their 80s and 90s that were transplanted 20 and 30 years ago, and they're going to live a lifespan that's the same as it would have been in the absence of a liver transplant.
Why was Lindsay so stand out so much? I mean, she was only 2. Was it her age?
Well, it was unusual in those days, compared to now, to offer liver transplantation for very, very young children. We now transplant children as young as 6 weeks of age. And in those days, because we didn't offer living donation, you also had a very, very long wait for donors that were the appropriate size. Right. So you really needed another child to pass away in order to get a liver for another child, or you had to take an adult liver, divide it into 2 pieces, and use the smaller piece for the child as well. Both of those things were uncommon and relatively new procedures back in the days when Lindsay needed her liver transplant.
Is the prognosis better today? I mean, have the techniques changed? Is there a better quality of life 30 years later?
No, absolutely. The medications that we use today to prevent our patients from developing rejection are much better tolerated. We give them in much lower doses, and I think we've developed really great skill set in terms of titrating those medications to the individual patient. So it's not a cookbook anymore where everybody gets the same thing in exactly the same way. I think with experience and thousands of transplants under our belt, we become better at using the drugs that we have and better at choosing the drugs that we use as well. So patients who remember what they were on after their transplant 25 years ago marvel at the fact that they come into clinic these days on maybe 1 capsule in the morning and 1 capsule in the evening as their entire drug regimen. So I think we've gotten better using the tools that we've got. We've also gotten better at selecting patients for transplant. With experience, I think we're much better at knowing when someone is too sick to get through a liver transplant, and also in determining when someone is perhaps too well and it might be better off in that individual case to defer the transplant also. The biggest change has been the increase in the availability of organs. Organ donor rates in this province have risen substantially over the last 2 decades, with a 30% increase just in the past year alone. So we have more organs available, but we're also able to use organs now that we weren't able to use even 10 years ago, because we have new technology that takes lungs, for example, that would have been unusable a decade ago, and it puts them on a special machine that was developed here at Toronto General Hospital and turns those lungs into working organs that will function extremely well in a transplant recipient. That technology is now being used in livers and in kidneys, of course, as well. Wow. So more organs to begin with, but also a greater proportion of those organs is now available for us to use in our transplant recipients.
Aren't you also able to use organs under a different definition of death?
Absolutely. The biggest increase in organ donation has been the so-called donation after cardiac death donors. Historically, donors had to become brain dead. No evidence of neurological activity in the brain before we were allowed to use the organs. Now, if an individual is terminally ill with no hope of recovery, care can be withdrawn, the donor passes away, and within a few minutes the donors can be retrieved and used successfully in our recipients. And there's been an enormous growth in that population of organ donors, and those organs work as well as the organs that we were retrieving from the traditional neurologically brain-dead donors.
So it sounds like we've come a long way since Lindsay first got her liver when she was just 2. Where would you like to see us, though?
Well, I'd like, frankly, to be out of business. I would like the need for organ replacement to be eliminated. I know that will never happen, But I think particularly in my area, lifestyle choices that are resulting in high prevalence of fatty liver disease is having the biggest impact on the growth of our waiting lists. And those are choices that people make that perhaps could be reconsidered and managed in a more effective way. The gap between supply and demand continues to exist. Our waiting list, despite our best year in our history, our waiting list is exactly the same length as it was a year ago. We had exactly the same number of deaths on the waiting list last year as we did the year before and the year before that.
How can that be when you have a 30% increase and yet the death rate is the same and the wait list is the same?
The demand for transplant is increasing at exactly the same rate as the supply.
Wow.
And in liver disease, it's the demand, the pressure from fatty liver disease and the impact that it's having on waiting lists. And it's expected within another decade that fatty liver disease will be the leading indication for liver transplant in North America.
Whereas right now it's kidney.
No, I mean the leading indication for liver transplant currently is still hepatitis C,
I see. Okay.
which is now curable with very safe and very well-tolerated medications. Kidney disease is becoming more common with the aging population with higher rates of hypertension and diabetes. Dialysis units are bursting at the seams, and the fact that kidney transplant is better than dialysis is very, very well known. So that patient population continues to burgeon as well. There are many, many diseases or many, many patients that we're unable to offer a transplant to because we already have a high mortality rate on our waiting list. And I think if the organ supply continues to grow, we'll continue to identify patients that we might consider for transplant today that wouldn't have been considered for transplant even a few years ago. Older patients, patients with multiple other disease problems, patients who've had previous transplants. The group that currently is deemed too high risk in the setting of insufficient organs might be considered acceptable risk in the future if the organ supply were to continue to grow, and that's what we're hoping for.
Do you think, my last question, because I know you're so busy, do you think that Lindsay changed a lot of the mindset some 30 years ago?
I think she did in two respects. First of all, the technical side of things. You know, doing a liver transplant in a child of that age was still considered somewhat revolutionary, and I think it was reassuring to everyone in the team at Sick Kids and ultimately the team here that we could do this and get away with it. But also, I think the fact that someone transplanted way, way, way back then lasted for so many years really offers us a bit of a insight into what the future would bring. And we now have patients who are more than 30 years out from their livers on the adult side. We have patients who have survived, as I mentioned, into their 80s and 90s. So I think she was perhaps one of the first indicators of how successful transplantation could be in the long run. And our patients every day now are living proof of that.
So she's left quite a legacy.
I think she has. Yeah.
Okay. Is there anything you remember most about her or that case?
Well, I mean, she was most of the time she was positive and a fighting individual as well. I think her accumulated diseases got the best of her at times as well. But I think what struck me about her, as does for many of our patients, is the spirit that they bring to this. Because having a transplant under any circumstances isn't easy. We put enormous demands on our patients in terms of hospital visits and medications and blood tests and in tests that we do as well. It takes an extraordinary individual, if I can put it this way, to put up with all the things that they need to do as well. And she was an excellent example of that. And so I think at the end of the day, it was that fighting spirit that probably will be her lasting legacy.